So I'm going to talk today about the biology of fat mass regulation, but I'm not going to do it in the context of a lecture on purely on biology, because this is a symposium or a workshop on stigma. And I want to say a few things about the biology of obesity that I hope, if people understood it better, would address the issue of stigma in a more effective and more efficient way. Obviously, I've been listening to the whole program this morning, and I think it's been fascinating. It's been a terrific program. I want to complement that now with a little more information about obesity. So, what is obesity? You all know that it's a complex, chronic, and possibly progressive disease. We don't really know if it's progressive. We know that people get heavier over time, but that doesn't necessarily mean progression of the disease. It may just mean less good control over time. Why is it a disease? And this is the critical component. It results from abnormal metabolic regulation of body fat mass. By itself, it causes pathology, diminishes health. It is a risk factor for other diseases, as I'll talk about, but it's a disease in its own right, independent of complications, of which there are more than 225. So whatever the external causes or contributors, whether it be the environment, whether it be drugs, whether it be genetics, whether it be something else, the final common pathway is internal to the body and reflects disrupted physiology. And just to make that clear, there's also an epidemic of nut allergies in the United States, particularly peanut allergies, which has arisen over the last 50 years. And we know that epidemic is due to changes in the environment. Some people believe in the hygiene hypothesis that during the early phase of life, when tolerance develops immunologically, there's something about too clean an environment that doesn't allow for tolerance and increases the likelihood that people will have peanut allergies. But whatever the cause, everybody understands that if you need an EpiPen, if you're getting anaphylaxis from eating peanuts, that there's something wrong with your immune system. And so the final pathway of peanut allergies is something wrong with your immune system. And in the same way, the final pathway for obesity is something wrong with the metabolic regulation of body fat. And when I say the metabolic regulation of body fat, it's not only how much you have, but where you store it. So obesity is a disease of not only excess fat, but a disease of abnormally placed fat, ectopic fat. And what obesity is not, it's not the cultural desire for thinness. And this is a critically important distinction. People who only have the cultural desire for thinness, they want to be thinner, that's fine. But if they don't have obesity, that can confuse regulators, it can confuse the public, it can confuse people with obesity into thinking that this is purely a social disorder or a cosmetic disorder. Now, obviously, as shown in this Venn diagram, there are people with obesity and the cultural desire for thinness. Obesity dominates. If you have the disease of obesity and you need to be treated for it, it's severe enough that you need to be treated for it. Having the cultural desire for thinness on top of it is only a motivator. But what confuses people and what feeds stigma is that people view their colleagues, their friends, themselves with this desire to be thinner without obesity as being what people with obesity experience, which is not the same. Now, the fundamental question then is obesity a disorder that's best treated in the healthcare system, or is it best treated in a shopping mall? And we know that for the last 60 years, obesity has been treated, or at least the cultural desire for thinness has been treated in shopping malls. And so why do we take it on in the healthcare system? And what does that mean for our understanding of the disease? Well, the purpose of healthcare is to relieve suffering arising from disturbances in the human body. Obviously, we're not relieving all suffering in the world. Wars and other things can lead to suffering that we don't have such control over. But what causes suffering is symptoms, disability, and fear of complications, of dying, of developing a disability in the future, of not being able to live a good and productive life. The goals of obesity treatment then should be consistent with the purpose of a healthcare system to relieve suffering, as I've described. And of course, weight loss is a goal of obesity treatment because weight loss leads to beneficial effects. If it didn't lead to beneficial effects, if whatever caused the obesity caused permanent effects that weight loss would not improve, then we wouldn't aim for weight loss. But beyond weight loss, we want to improve obesity symptoms. And unlike hypertension, diabetes, fatty liver disease, kidney disease, diabetes, what we can say is that obesity does have symptoms. It has ingestion-related symptoms. Hyperphagia in some people, meaning that they're too hungry all the time. Excessive craving, diminished satiation or satiety after a meal, excessive food focus, food obsession, what's often called food noise. Those symptoms can be rapidly improved upon initiation of an effective treatment, whether it be surgery, medications, lifestyle. If it's effective, truly effective and physiological, you can see improvement in the ingestion-related symptoms very quickly. From a physical perspective, physical instability, discoordination, fatigue, dyspnea, difficulty breathing, diminished ability to perform the activities of daily living are frequently associated with the severity of obesity. And those symptoms, and again, when we talk about fatigue and dyspnea, difficulty breathing, we're talking about it in the absence of having heart disease or lung disease. This is just from the obesity itself. And those symptoms can be improved with substantial weight loss, if indeed that's what it takes to improve those symptoms. But some amount of weight loss is required. It takes longer. And finally, the dysphoric symptoms, the secondary to stigma, social and economic exclusion, therapeutic nihilism, frustration from failure of previous therapies or attempting to lose weight on your own without the benefit of medical intervention. When I say medical intervention, that's lifestyle plus drugs plus surgery, depending upon what you need. Those dysphoric symptoms can improve even faster than the ingestion-related symptoms because they can be improved with effective, respectful, and supportive care on the very first visit before anybody even gets started with therapy. So the other thing that we want to do for obesity treatment is improve existing obesity complications because they create the fear. And of course, there's the fear of future obesity complications. So when we think about, is obesity a disease, we can ask the question, is obesity something that the healthcare system is designed to fix? And look at all the ways and the goals of obesity treatment that fit completely within the healthcare system's mandate to improve suffering or decrease suffering from disease. Now, body fat mass, as it turns out, is physiologically regulated. As you've heard from many speakers already, it is not a simple matter of bookkeeping calories in and calories out. That's how a tub regulates how much water is in the tub. You turn on the tap, you open the drain. That's not how the body regulates. It regulates itself. And at multiple stages during the life cycle, the body regulates how much fat it has and where it wants to put it. Loss of baby fat can occur without a diet. Fat changes with puberty, gain of fat in girls, a slight loss of fat in boys, again, occurring without a diet. Fat changes during and after pregnancy and lactation. Fat changes with aging and menopause. And all of these fat depots are changing. Baby fat is in a different place from pregnancy fat and all of the other times of life. At any given time, fat mass is defended by a process called metabolic adaptation. And that metabolic adaptation is physiologically good for us because we need to regain fat after resolution of an acute illness or an acute injury. But we also will see that protection protects us against obesity. There's fat loss in response to acute overeating, as we might see during the holiday season. But that fat loss that you see in response to acute overeating or even chronic overeating also prevents people, say, young kids who their parents may think they're too skinny. It prevents them from gaining weight and keeping it on. At that stage of their lives, those kids are designed to be skinny. Fat gain in response to caloric restriction is the one that we focused on because that's the thing. It's the protection of the protection of how much body fat the body wants to have that continues despite obesity, that makes simple calorie restriction based dieting ineffective over the long term. Now, there are lifestyle changes, improving the quality of the diet, having a different balance of nutrients that can change the physiology. A simple calorie reduction has been proven time and again to be met with metabolic adaptation because the body thinks that it's just lost weight because of an illness that it's recovered from. So obesity occurs when this regulatory system seeks and defends an inappropriately high fat mass. But the key thing is, despite that inappropriately high fat mass, which is the cause of obesity, the final cause of obesity, the body is able to defend that fat mass and does defend that fat mass, which of course is inappropriate given the height of it. So in obesity, the target fat mass is dysregulated. I'm showing a number of environmental factors that can push it up. I'm not showing pollution, which is another one, certain kinds of additives that are put in foods that are also can do it, because we don't have as much control over that as we have over the ones shown here. But there are a number of different environmental factors that convince the body that it needs to store more fat, therefore needs to have store more energy, needs to have more fat to store that energy, and therefore the weight goes up and the rest of what happens. So the body vigorously defends that fat mass in obesity as well as in normal weight through metabolic adaptation, which in humans is primarily through increased appetite and less so in decreased energy expenditure. But in humans, as in animals, increased appetite and decreased energy expenditure are the hallmarks of metabolic adaptation, with an increased focus on food, an increased obsession about food, again, that same food noise, increased hunger, decreased satiation, satiety, decreased thermogenesis, which is the way that the body decreases energy expenditure. It's mediated by a number of different physiological processes, including changes in hormones that are secreted by the pancreas or by the gut, hormones that are also secreted in the brain that regulate these processes, and it leads to regain of the lost weight. But effective anti-obesity therapies, ones that are truly effective over a long period of time, actually help to reverse the process that causes the body to want to increase its body fat mass and energy stores in the first place. And examples of that, notable examples of that, are bariatric and metabolic surgery, effective anti-obesity medications, and as I've mentioned, lifestyle changes that address the very issues. If you have obesity because of circadian rhythm disruption, improving your circadian rhythmicity is going to be effective. If you don't, if your obesity comes from chronic stress, it may not respond to diet or circadian rhythm fixing the circadian rhythm disruption. So why is obesity a disease? It's a disease because it results from this abnormal physiology that makes the body want to have more fat and do everything in its power to get there and stay there, which includes appetite changes. It directly causes pathology and symptoms and suffering, as I've already described. By itself, it diminishes health. But it also causes other abnormal physiology, inflammation, abnormal cell growth in certain areas, and other diseases. And so it's a risk factor for other diseases. But just because it's a risk factor for other diseases doesn't mean that you need those other diseases to have a disease. Obesity by itself is a disease. It needs to be recognized, respected, treated, talked about, prevented as a disease in its own right. So if we want to treat obesity more effectively, and if we do take the approach to treat obesity more effectively, we will by nature respect the patients, respect the disease more, and therefore decrease stigma automatically. But we have to fully understand why it's a disease and how that disease differs from the cultural desire for thinness, which in many cases only adds to stigma. We need to understand what being a disease means for the effective care of obesity, not merely starving ourselves in order to try to reverse it, but actually changing the physiology back toward normal. We have to fully understand the barriers to effective obesity care, which include stigma, but also include a lot of other things, like the way we talk about obesity, independent of stigma. We talk about obesity, we talk about healthy obesity, as though we never put the word healthy in front of other diseases. Diseases are not healthy. Even if they don't have, we may say uncomplicated, we may say mild, but we don't say healthy. We don't use the word recidivism for any other disease besides obesity, despite the fact that recidivism means return to criminal behavior as its number one meaning. And most of all, we have to keep the needs and goals of all people living with obesity foremost in our minds. We're treating them. We're not treating ourselves. We're not treating the environment. We're treating people with obesity. And many of those people, unfortunately, have been previously misled by the bias, stigma, blame, and discrimination that surrounds them, what many people call internalized bias. So not only do we have to support them through that, but we have to educate everybody, people with obesity, people who take care of obesity, people who make policy about obesity, and the general public, that understanding this disease will, and understanding that it is a disease, will allow much more effective policy and much more effective treatment, and ultimately on a population level, a decrease in the rate of obesity, which to date has not been seen in any country over the last 50 years. Thanks very much. I unfortunately can't hear you if you're talking.
Can you hear me now?
I can now.
Okay, perfect. Thank you so much for your presentation. I wonder if there is any question from the floor. Just one here, please.
Hi, good afternoon. Thank you very much, Professor Kaplan. My name's Nadia Isaac. I'm a person living with obesity. Your last point that you just finished on with regards to recognizing obesity as a disease, the common narrative here in the UK is that, oh my gosh, if we recognize obesity as a disease, then we're going to have 3 million people rushing on to the hospitals to say they have a disease. And that's the big fear, that it will then overload the health system and we are all going to, be in big trouble. So how do you address that sort of argument?
It's a great question. So I think that the important thing to recognize, because I'm getting feedback, if you can just shut off thanks. So it's a great question. And I start by saying that obesity care is a scarce resource. Given the size of the population with obesity, we have to face the fact that the population with obesity is very large. But the population with diabetes is large, and the population with fatty liver disease is larger, and the population with dyslipidemia is even larger, and the population with hypertension is even larger. And if you take those other metabolic diseases, they actually outnumber obesity. But we have effective therapies for them that the healthcare system is able to manage. But in obesity, we don't have enough of three things that make it a scarce resource given the population who has obesity. And they are, we don't have enough providers to take care of the patients who are capable of taking care of the patients and interested in doing so. We don't have enough money to pay for the care because it's very inefficient care right now. It's not efficient the way some of the other diseases are efficiently treated. And we don't have, if we want to use medications or surgery, we don't have enough surgeons and we don't have enough drugs. Frankly, the companies can't make enough drugs. When you have a scarce resource like livers for liver transplant, you prioritize the patients who need them. And what we need to do in obesity is to prioritize the patients who need it first. And over time, as time moves on and we get more capable of addressing the size of the problem, we will be able, over probably 10 to 20 years, be able to handle the problem. I don't think the fact that there are a lot of people with obesity should be daunting to us. Not everybody with obesity has severe obesity. Not everybody with obesity has complicated obesity. Not everybody with obesity needs medications or surgery. So we're just going to have to prioritize and grow into an effective approach to this disease.
On that note, let me give some information. There is a group of obesity experts and patients representatives, including Professor Lee Kaplan, myself, Rachel, Martin, many others here, Vicky, who are working at Lancet Commission organized by the Lancet Diabetes and Endocrinology Journal. We have the chief editor here with us. And this group has tried to address exactly that question, how we define illness and obesity in order to facilitate managing priorities and recognizing disease where there is, and of course maybe recognizing pre-disease states if possible, so that policymakers will have a much better a clear picture, not a blurry picture as we have today, which is probably where the problem is. Lee is making a very good point that obesity should be considered disease. In some circumstances, the pushback that we hear from many is that you have a poorly defined condition that makes that proposition a bit difficult to accept for many healthcare providers and policymakers and beyond. Unfortunately, we are, because of technical reasons, we are a little bit behind with time, but if you don't mind staying there, Lee, for the panel discussion, there might be questions that we can use at that time and address to you as well, if you can.